It is such a pleasure to be here with you. Thank you for joining from around the world. This is Joe Harris, the director and founder of the Global Health Politics Workshop. We're here at the Pardee Center for the Study of the Longer Range Future, our generous benefactor here at Boston University. Glad to be with you for the third installment of the fall semester. Here, a conversation with Dr. Thurka Sangaramoorthy. Dr. Sangaramoorthy is a professor of anthropology at American University whose research has explored how to improve care for people living with HIV and how we can develop more effective care for non-citizen immigrants. Her latest book, which she'll talk about today, Landscapes of Care, Immigration and Health in Rural America, examine how immigrants from Latin America and the Caribbean navigate the U.S. healthcare system. She also recently just came back from serving for 2 years as refugee coordinator for the State Department's response in Sudan and South Sudan, working at the U.S. Embassy in Addis Ababa. We're really pleased that she could join us today. If you can help me welcome her, that would be wonderful. Thank you.
Thank you so much for having me. It's always a great pleasure to talk to those in global health or global health programming because it's invariably an interdisciplinary sort of crowd, which I really love. So thank you all for having me here, making the trip possible. And I really hope that we can have some really great conversations afterwards. So I'm going to give you a little bit of an outline of what the talk today is going to be about. Really talking to you about what the research and the book specifically is about, how the work was done. Right. Again, for interdisciplinary audiences, I'm not necessarily assuming, about certain kinds of methods. So I want to be really specific. Some major contributions, both intellectual contributions, right, theoretical sort of interventions, but also practical ways of thinking about immigration and rural health together. Some major key findings. The book's is tackling two issues that are complex in themselves, but then actually putting them together. So I picked out a few key findings that are really important. Really thinking about rapid rural immigration and why that actually matters, not just in the US, but in places around the world as well. What configuration of rural immigrant life is, actually sort of thinking about place-based work for immigrants and not just immigrants in general. Immigration beyond legality, in terms of thinking about one of the major interventions in the work and the book, just like the political context right now is very much around the southern border, right? Really, again, thinking very much around sort of the legal constructs of whether someone should be here or not, or deserves to be here or not, or has the right to be here or not. And really thinking more beyond that and beyond sort of what the reality is for various different immigrants and why that actually matters beyond legality. This concept of landscape of care, I know that's the title of the book, but what that actually means. It is very spatial, and it's a different way to think about healthcare in general and why that's important. Sorry, this is supposed to be community and care. But just this notion of how care becomes actualized and how people actually perceive what that actually means in relation to community, and how that's different from thinking about moving us away from thinking about healthcare systems per se, really thinking about community care. Okay, so what is the book about? So my research and book is really about immigrants and non-immigrant residents and how they come to understand and practice care in rural settings. It's set in the rural, very politically conservative region of the Eastern Shore of Maryland, and I'll have a map a little bit later if you don't exactly know where that is. And it really explores the relationship between three things, between immigration, health, and what I'm calling rural precarity. And I'll go into that in a little bit as well. And it does two things. And it's positioned in very sort of historical moments in the US, but perhaps also globally. I'm actually tracing the aftermath of the Affordable Care Act, what some people still call Obamacare, which is actually a major significant sort of policy change in our country's history. It is the healthcare system's most significant regulatory overhaul and expansion of coverage since the passage of Medicare and Medicaid in 1965. I also document the repercussions of Donald Trump's 2016 presidential election, particularly his administration's sweeping changes to the federal immigration policy. This included several things, as you remember, right? Heightened immigration enforcement and deportation, reduction of refugee and asylee admissions, an expansion of the public charge rule, if you remember what that was, that limited green card and temporary visa applications during that time. So it was a pretty sweeping sort of things that he sort of instituted via mostly executive orders, but other kinds of policy measures too. So a little bit about how I framed this work and why the theoretical framing is really important. This is not theory or theoretical framing that I came into this work with. This is something that I think made a lot of sense as I was kind of writing the book and thinking through the process of everything, pretty much up to 10 years worth of work and what that actually meant. When I first went into the Eastern Shore, I was a scholar of immigration that had worked in healthcare for a very, very long time. And I wanted to go study immigration. I wanted to understand what it was like in places like the Eastern Shore, where there weren't a lot of immigrant communities there to begin with. And when I went into the field, all I heard was that I could not understand immigration without understanding rural health. And I didn't actually know what that meant. And I didn't know for a long time what that actually meant. So it took me a long time to actually sort of think through this. What I'm saying is, for those of you who are students here, it's okay not to have theoretical framing as you begin the work. Sometimes it kind of comes together towards the end, and that's perfectly okay. The book's theoretical framing is on precarity. I use precarity to think through how immigration and rural life are connected. I actually take to heart what people told me and taught me, that somehow these things are connected. And what might that be? Why might that be? Why is that important? I think precarity is an incredibly helpful concept to think through the daily struggles of living, how people actually make a life for themselves in places like Maryland's Eastern Shore. Precarity, if I ask you what precarity means, right, there may be sort of some renderings of longstanding vulnerability, but it also means just a general state of uncertainty, of not knowing, right? That comes from different social and economic forces. But for me, precarity isn't just a theoretical framing. It's actually a method. It's a way that I was able to be much more deeply attentive to how immigrants aren't experiencing these struggles alone, but actually in relationship to each other, right? With people who live in rural spaces and the various care networks that they kind of form together. In my work, precarity is a shared state of living that actually binds people together. I argue that precarity is what allows for mutual dependency and care to happen, and what makes living possible under very challenging times. When precarity is thought of in this way, it also allows us to shift the framing of health and healthcare from spatially bounded systems into a field of relationships. Instead of focusing on healthcare systems, which don't necessarily exist in the same way in rural environments, I look at the complex formations of what I'm calling a landscape of care. And I'll talk about this later, but I want to say that the notion of landscape actually better incorporates the irregular, the informal, sometimes the illicit, improvised reality of immigrants' care experiences in rural regions and many other places worldwide who are struggling with global migration and health governance challenges. So in my work, precarity allows me to see care both as an object, right, but also as a relationship. And what precarity does also is allows for the broad diversity of immigrant voices and experiences who actually live and work in rural landscapes. Oftentimes, when we think about the scholarship on immigration, we tend to focus on very particular immigrant groups, which has led to two related outcomes. One is that we exceptionalize each group's experiences as unique. or we render all immigrant experiences the same through the framework of equality, right? Precarity actually allows us to move away from these static binary approaches to focus on more of the way in which spatial, temporal, and racial logics actually affect immigrant experiences in rural regions. And I'll go through a lot of these in the findings. So here's a map of Maryland's Eastern Shore. For those of you who don't know Maryland very well, most of Maryland is actually rural and is officially considered rural. The west of Maryland is pretty much Appalachia, and all of this on the eastern side is where I worked for this project in particular. The Eastern Shore is considered a new receiving destination. Oftentimes in demography and in immigration, that's what we consider places without high concentration of immigrant communities. Many immigrants who come to this region are coming here to work in labor markets, mainly in agriculture, but also in poultry. And what makes this really unique is that because it's in the Chesapeake, it's surrounded by water. They're also coming to work in seafood processing as well. Latinx and Haitian immigrants make up the vast majority of those working and living in this area. Some are coming directly from Latin America and the Caribbean, particularly Mexico, Central America, and Haiti. Others are actually migrating from other parts of the East Coast and throughout the US. So those who are coming here some are on temporary work visas, and migrant farm workers from Florida and other parts of the US arrive in late spring and early summer, and they stay throughout the growing season. Migrant Mexican women who work in crab processing are also following the same kinds of timeframes and employment patterns, and because they are seasonal. Others, like those who are working in poultry processing plants, are settled here a little bit more permanently. In rural regions, foreign populations are increasing by as much as 90%. Oftentimes they're also in the thousands in terms of the relative change in these numbers. We're not talking about sheer numbers, like the raw numbers, but the actual changes in the percentages of immigrants. And these are, I'll talk a little bit about this when I talk about rapid rural immigration, but these numbers are really high. These percentage changes are really high, and they're happening very quickly. And the one thing that I want to also emphasize in doing work like this is that there's very little information on these communities in general. And whatever exists actually exists only in the census, because it's really difficult, because much of this population is highly mobile. So it's really difficult to sort of locate these numbers and where people are. So how did I do my work? I draw on the work that I've done with Haitian and Latinx immigrant communities in rural and urban settings throughout the US since 2000. So I've been doing this work for a long time, but research in Maryland actually starts in 2013. I use traditional ethnographic methods, including hundreds of hours of participant observation and individual in-depth interviews that were used to conduct the research. And the research moves in various different places. It moves between community health facilities, service organizations, homes, work sites, and immigrant enclaves to detail daily life and social interactions between immigrants and care providers. Formal interviews and informal discussions with local researchers, academics, health and social service providers, and immigrants help solidify the kinds of analysis that I'm making here. And if you want to know about the people that I actually did the interviews with, roughly about 79% were women in terms of the immigrant individuals that I worked with. And they included roughly half and half in terms of those who identified as Hispanic, Latino, Mexican, or Central American, as well as those who identified as Haitian or Black. So roughly about 37 to 25%. So why did I choose the methods that I did for the kinds of questions that I've had? Which is a really important question to ask yourself as you're doing research. So a lot of work in the field of immigration studies, especially around health, is really about how immigrants experience healthcare. I wanted to actually look at how systems are actually influencing how immigrants experience both their bodies as well as the care that they receive. It's a slight shift in thinking that moves away from behavioral explanations and simplistic understandings of health delivery and provision. And for that, I really needed to do ethnographic work. I also wanted to understand how people themselves articulated what health meant to them and how it related to life in rural spaces. I wanted to take seriously what people said was important to study, not just immigrants and immigration, but also rural health systems and what that was, how was happening as well. So some major contributions that I think that I'm making to these various different fields is that even though initially I wanted to study immigration, the challenge of rural health pretty much came up all the time in my field site. And it was really hard to ignore. And for a long time, I didn't really know what to do with that. For many, immigration experiences could not actually be separated from rural health delivery and provision. The people that I worked with insisted that immigration related issues such as belonging, citizenship, deservingness, all the things that we think about when we think about immigration, were vital to also understanding rural health provision and delivery. Their demands actually tested the limits of my own understanding and how I was trained about immigrant health. And this is what actually guides the research's primary interventions that I talk about in this book. The work is, I think, very interdisciplinary. It addresses it not only goes back between public health and anthropology, but it also looks at the relationship between the political concepts of rights, the racial capitalist formations of value, and the moral assessments of health-related deservingness. I also look at the epidemiological and the lived implications of immigrant health as well. Another primary intervention is to move our understanding of immigration and health beyond a singular focus on legality and criminality, and to consider the impact of race and racialization, gender, as well as space and place and time on immigrant and migrant experiences of seeking, receiving, and fashioning care. It addresses the role of immigration and health policy, both together. Often we think about immigration policy very separate from health policy, but how these are actually working in conjunction with each other and shaping and influencing the complex care pathways for vulnerable populations. It documents local concepts of reception, organizational culture, provider attitudes and behaviors, and would argue that these are really critical to how immigrants actually experience health and healthcare systems, particularly those who are racialized as Black and those who have various different kinds of legal status. I also think that it advances our understanding of public policy, social and cultural dimensions, particularly individual perceptions and behaviors and community relationships. Often we think about policy as big P policy, right? Something that exists out there that policymakers control, but it actually has real effect in the world. And what that actually looks like is also really important to document. A vital aim of the work, especially this book, is to attend to questions of who deserves care and the role of the state and organizations in providing healthcare that actually affects all of us in some way, right? What's happening in rural America is not all that different from what's happening and what might happen elsewhere. So I'm going to read a couple of excerpts from the book. So this is the first narrative. This is how the book begins. Summer in Maryland means one thing: blue crabs. Every summer, residents and visitors flock to Maryland's coast to get their fill of blue crabs. Famous for its sweet, tender meat, the blue crab is an essential part of the region's culinary heritage. There are few things more enjoyable to Marylanders than sitting with family and friends, tearing into a bushel of blue crabs coated with the local seasoning Old Bay, and washing it down with ice-cold natty bows. Eating blue crabs in the traditional manner is not for the faint of heart, or for those who prefer eating with utensils and white tablecloths. In restaurants and homes, people pile steamed and seasoned blue crabs in the middle of the table covered in paper. Then, using small mallets, knives, and bare hands, diners break open the hard shells and extract the juicy meat inside. It's a messy experience, one that is quintessentially Maryland. The Latin word for blue crabs is Calanectus sapidus, meaning beautiful swimmer. Blue crabs get their name from the sapphire-colored claws and are one of the most iconic species in the Chesapeake Bay. In Maryland, hard shells are steamed rather than boiled, a common practice along the East Coast and Louisiana. Marylanders insist that steaming gives crab meat its moistness, and the flavor is best appreciated by cracking and eating the steamed hard shells or feasting on soft shells. However, suppose you would instead not go through the hassle of picking crab. In that case, it's easy to buy fresh crab meat. Buy the pound at the local grocery store, or to enjoy them steamed or sauteed, as in Maryland crab cakes or crab imperial, or in crab soup or in crab dip in any area restaurant. In Maryland and elsewhere, eating blue crab is a communal activity, and it's meant to be enjoyed with family, friends, or large groups. As a result, people often experience picking crab as a pleasurable experience and a social exercise. Even those who purchase fresh crab meat at the grocery store or a restaurant rarely consider how it was processed or who picked and cleaned it. Many people forget or overlook how crab picking is a livelihood for many, mainly poor women. For generations, African American women from Maryland's rural maritime communities did the grueling job of picking crab for crab houses on the Eastern Shore. Today, fewer than 10 crab houses are left, and the workforce is exclusively female migrant workers from Mexico. Like in many other places around the world, Maryland's rural Eastern Shore has come to rely heavily on labor of non-citizen immigrants. Yet policymakers and the general public often regard their presence as illegitimate, threatening, and a drain on national and local resources, ignoring how their illegality or foreignness often place them in positions of considerable social risk. In recent years, the national spotlight on border walls, immigration bans, the inhumane treatment of undocumented immigrants at detention centers, and the disproportionate impact of COVID-19 on immigrant farm workers and meat processors has raised some public awareness of the plight of immigrant workers. But immigration remains an increasingly polarized issue among rural Marylanders and Americans more broadly. In Maryland, for instance, comprehensive news coverage of increasing visa caps for migrant workers, COVID-19 pandemic restrictions, and crab shortages have left many concerned about the fate of the crab industry. Politicians and influential business owners have appealed to the federal government to increase the number of visas the countries provide to female Mexican migrants, arguing that the H-2B temporary worker program is vital to the Eastern Shore's seafood economy. These discussions on the dire need to increase immigrant labor occur in some of Maryland's most politically conservative areas, where there's strong support for federal and local anti-immigration rhetoric and policies. So I'm going to go through some of the findings. And the first is really rapid rural immigration. I think this is where I'm not sure very much has been, it should be talked about a lot more. So traditionally, when we think about immigration, we think about specific states. And raw numbers, those are still very much the states where a large number of immigrants go and where they're concentrated. So New York, Texas, Florida, et cetera, right? But since 1990, and even before then, actually in the 80s and perhaps slightly in the late 70s, there's been a steep rise in immigration in the US, and these numbers or percentage differences have been the highest in rural America, in rural sort of settings. Some rural counties are experiencing growth rates over 1,000% in their immigrant populations, who have filled essential roles in labor force and mitigated the growing decline in rural populations, right? But despite their valuable contributions to rural communities, immigrants are not necessarily treated well or openly welcomed by local residents. And I think we recently saw that in Springfield, Ohio, for instance, of what happened during the presidential debates and then what happened afterwards. So there's been a lot of focus, for instance, on certain places like Springfield as well. Um, what happens when we think about immigration is that we have large demographic studies, right? They help us recognize the impact of policies on people's migration trajectories. They help us really think about some of where people are going and perhaps why they're going to certain places. But they tell us very little about how diverse structural dynamics actually shape rural communities' reaction to what they would consider newcomers and very large numbers. Survey-based work can also overlook important details related to the everyday life of immigrants and the politics of those who want to belong in certain spaces. So even as researchers, what we tend to do is we tend to think about immigration very much in these sort of static terms, right? Whether society is going to embrace immigrants, right? Are they going to be integrated or are they going to be excluded? And in rural Maryland, and I would gather in very rural spaces as well, where these demographic shifts have been really, really sudden and drastic, it's much more complex than are they going to be integrated or are they going to be excluded. In rural Maryland, for instance, what would often happen is people would say, I'm really glad they're here. They're keeping these jobs alive. They're keeping these industries alive. I'm really happy that my children go to school with immigrants and have this diversity of people that they're going to school with or playing with that I never had growing up. But in under-resourced spaces where there's a lot of pressure, when you have a large sort of influx of immigration and you don't have a lot of resources, right? When those pressures come, oftentimes who people blame are the immigrants, other newcomers, right, as the reason. And so it's a really complex landscape, and I don't necessarily think that we can just talk about it in terms of immigration, integration, and exclusion, especially when you have these rapid sort of shifts in demographics. The other thing that I think happens, not just in research, but also in terms of policy and how we think about immigration, is that in the US and globally, immigration is coupled with territoriality, criminality, and how the nation state actually relates to people, right? You belong here. Do you not belong here? Should you be here? Did you come here legally, right? It's the nation state that actually makes this kind of determination. And so we often consider legality as a central organizing feature of immigrant life in the US. And legal status has become the crucial mechanism through which immigrants experience health and healthcare. This is how we sort of come to know this. In fact, we think about immigration status and legal status, we use that interchangeably, right? We don't really think about these things as different. And so they've actually come to mean the same thing in many ways. This predominant framing actually shapes research, it shapes policy. It definitely shapes public understandings of legal belonging as the primary way that people experience health in this country as an immigrant. Right. But not all immigrant social life can be knowable or understood this way. Defining immigration from a very singular vantage point of legality actually flattens immigrant knowledge, experience, and the various social identities that people have, depending on who they are, what they look like, what their experiences are. Legality actually naturalizes certain narratives of suffering and vulnerability. It actually hierarchically positions individuals, communities, and nation states. It can actually inadvertently reproduce the discourses around immigration to equate it to inferiority and placelessness. Further, I think a preoccupation with legality in the US actually privileges narratives of specific immigration trajectories and immigrants, particularly non-Black Latinx immigrants from Mexico. And as a result, social science and public health scholarship on immigrant health can reproduce the very vulnerability that it seeks to describe and mediate. When I say the word immigrant, there's a particular sort of figure that pops up in our mind. And I ask you to question why that is. I think a focus on legality can also render the immigrant and immigration exclusionary term, something that becomes bounded, absolute, as a essentially a wounded, suffering, or vulnerable human being. In my discipline in anthropology, scholars use structural vulnerability and social suffering to describe the social dynamics of exclusion of immigrants without actually interrogating how these kinds of frameworks depend on characteristics of victimhood and deficiency related to legal status, and how this lack of legal status becomes the primary way immigrants can be deserving of care and attention. Because I've long worked with Black and Brown immigrants, my work has always shown that how racialization has impacted Haitian and Black immigrants' social and cultural and political marginalization. Racialization in this country and in many countries, having specifically worked with African migrants in different spaces, right, is an undeniable dimension of immigrant experiences in the US. It shapes individual and community relationships, health and well being, and the politics of care. Legality for a lot of Black immigrants that I work with is a concern, but it's not the primary concern. And another major thing is to really sort of understand why we ourselves have underdeveloped this notion of what rural life means in this country. In the field, many people that I worked with would call the rural Maryland land that time forgot. And for those of you who are probably not, this is an actual famous book. It was written by Edgar Rice Burroughs. It's a 1924 novel, and it's about it's a fantasy fiction essentially. But no one referenced this book, but people would say, "Oh, it's the land that time forgot. That's where we live." I think this is fascinating. This is a really fascinating analogy to think about. I think it's really fascinating because I think it's important to ask what it actually means to be a place or a community positioned outside of time and geography altogether. A land and a people who are forgotten, who are abandoned and left behind, right? What might land that time forgot mean, right? It's a place and a people who have been essentially sort of let go. People often describe rural spaces as flyover country. I don't know if you've heard of that term before, or if you've actually thought about what that means. It's a crude term for regions that urban, wealthy, white-collar Americans see only as worthy of viewing by air when traveling, right? Rural areas have come to be characterized as economically, developmentally, culturally, and politically different in the national consciousness, right? This also happens in our research. This framing actually happens. We tend to think about transnational mobility and globalization as exclusively urban processes. Conventional understandings of rural America is that it's overwhelmingly white, that it's racially homogenous, it's geographically isolated, and it's backward. In politics, rural America doesn't actually have a visible history outside of political and moral myth-making. It's come to rely on that. In the US, for instance, the ruggedness of the rural West is pitted against the weak, selfish, elite, progressive East and West Coasts. And we see that playing out in our politics now. These framings actually have what this does is that leaves out significant diversity and dynamism that's actually long been part of rural life. It is teeming. Globalization is happening in rural spaces. Yeah, we don't think of it that way. There's significant diversity in rural spaces, yet we think it's homogenous, right? What this sort of framing leaves out is that they neglect the rural South and Midwest, where many Black and Latino people reside and work, including immigrants. They don't include rural residents of Native Indigenous reservations. They don't recognize the vast influence of prison and migrant economies throughout rural America, right? When we think about health, right, COVID-19, I think even for those of different generations, brought a lot of attention to the longstanding crisis of rural hospital closures, right? We heard quite a bit about that. Rural residents have been saddled with severe access issues for a very long time, well before COVID-19 ever hit. And they travel great distance to seek healthcare services. And studies show that the situation is not getting better, it's actually getting worse. But this started happening long before COVID-19. There's been a steady abandonment of rural health by the state and by other development actors. Market-driven changes in the 90s toward managed care principle and emphasis on the corporatization of healthcare. This happened everywhere throughout the US in general. But in rural America, what's happened is that the rural residents actually feel these effects differently because there were fewer possibilities for actually cutting costs and increasing profit, because rural markets don't have the same kinds of ways to do this. To confront these challenges, rural health system increased integration and assimilation of providers and institutions into systems and networks. Despite, or more aptly, due to these fiscal austerity measures, the enduring problem of resources remains a hallmark of rural healthcare. So the ACA was actually designed in many ways to relieve some of these symptoms, but a lot of people that I worked with never felt like it did anything. Because many states with large rural populations actually didn't expand Medicaid at all, which offered them better capacity and funding to care for poor, uninsured people, most of whom are Native, Black, and Latinx. Under the ACA, and this is something that I witnessed all the time, right? Health centers and their capacity for managing patients have grown. There are more people who are able to access these services in ways that they weren't able to do before, but people still can't afford this care. Either because of restrictive health policies, right, or restrictive immigration policies. So a second reading. On a hot and humid afternoon in early August, I sat down with David, a local physician and community clinic director. David was one of the few in the area who worked with temporary migrant workers and more permanently established immigrant families. It was challenging to get a hold of him during the summer months because it was peak harvest season when many migrant workers traveled to the Eastern Shore to work on the region's agricultural, poultry, and seafood industries. David's small community clinic was often full of activity on the days that I had visited. I felt strange to be there when it was quiet and still. David was highly animated when we began to talk. I sensed he wanted to tell me something right away. Before I even had a chance to ask a question, he recounted an incident that had been ongoing for several weeks, something that he was working on right before I arrived. He explained, the nicest man came in one day. He wasn't feeling well. He complained of being tired, but he was very thin, active, and healthy appearing. David decided to run some tests on the man. The results were surprising. He was just spilling sugar in his urine. And I thought to myself, Lord, he's 42. So I asked him, have you ever been told that you have diabetes? When the man responded that no one had given him that diagnosis, but his father had diabetes, David decided to do additional tests. I did tests as best as I could. I get indigent rates from the lab company for certain tests, and I often eat the cost myself, and I don't even charge my patients. In this case, I told him he had diabetes and he had to be on insulin. I have an excellent relationship with the insulin rep, sorry. So I told them I have an undocumented gentleman. He can't go through patient assistance. David paused for a moment before continuing, surveying my face to see if I understood his patient's predicament. There are patient assistance programs through the pharmaceutical company if you're poor. But if you're undocumented, you're nothing. So I got the reps to give me medicine for him. He went on. He ended up in someone else's care. They called me and said, why are you doing this to this man? He can't afford this medicine. He doesn't pay for it. They said I couldn't continue to do this for him. I said, why not? Nothing is stopping me from continuing to do this for him. So I have an agreement that when he runs low, he comes by. When I inquired about what they wanted David to do, he responded matter-of-factly. They want me to put him on regular insulin, which he would have to do every 4 hours. I have him on a pen that costs about $400 that he can do once a day, and he's doing well. He can't test his sugar before he eats, or a sliding scale of insulin because he's in the field. Then shaking his head in disbelief, David uttered, insulin has to be refrigerated. What are you supposed to do? Have a little fanny pack of ice with him as he goes through the chicken houses at 110 degrees? So you have to be creative about the environment in which they exist. It's difficult at best, but it's difficult for everybody here. Referring back to those who chastise him, David declared, But the hardest problem for them to deal with is that I give them free care. And the point is that they have to purchase their medication or services. Then he paused for what seemed like a long moment, looking past me out the window and said quietly, "No matter what I do, I feel like I'm putting band-aids on things that need stitches." So the notion of healthcare in the traditional way that we understood it and how most of us interact with it, it denotes the continuum of public health and medical care that's often physically bounded. It's siloed. It's very much seen as ahistorical, right? It doesn't have a politic. It's politically neutral and tied to institutions. Spatially, many rural health systems tend to be composed of loosely integrated and ill coordinated public hospitals, community health centers, local health departments, and free clinics. On the Eastern Shore, individual providers, something that I can probably count on one, themselves offer the only semblance of a safety net or health infrastructure. Essentially, safety net patchworks and temporary improvised care are the default in many rural regions throughout the US. There's a lot of people like David. Rather than envisioning health systems through the standard tropes of organized, bounded, and singular identities, thinking in terms of a landscape emphasizes the actual relationships people have with each other, the multiple exchanges, and the violent kinds of trajectories that people actually go through to even think about what care means. Landscape actually includes formalized pathways to health, right? David works in an institutionalized setting. It is a health clinic, right? Where it's a physical building, you can walk in and get care. But David isn't just doing that, right, in the way that you're supposed to think about that care. It also encompasses otherwise invisible sites of engagement and social relationships of care that extends far beyond the reach of healthcare. David has a refrigerator where he keeps crab because that's sometimes how the payment comes through crabs or watermelons or whatever the season is, right? People often describe existing care systems on the Eastern Shore as band-aid or bastardized care. And what David means when he says, "No matter what I do, I'm just feeling like I'm putting band-aids on things that need stitches." What band-aid care actually means in this sense, it's a quick fix. It's a temporary remedy, right? When we think about what a band-aid is supposed to do. And band-aid care is seen as something lesser than what is ideal, right? It fails to actually address the long-term needs of those deemed most vulnerable. Yet Eastern Shore providers and immigrants engaged in various care practices that weren't just limited to addressing immediate health needs. They did things like they rationed, they bartered, they hoarded medicines, they did willful noncompliance, right? David sometimes doesn't charge for the stuff that he's doing. And goodwill are primary modes of caregiving and delivery. So I would argue, and most people would argue, that Band-Aid care is actually a response to individual immediate needs, right? Getting him insulin. But it also makes his life possible, right? He got the expensive pen because he cannot inject insulin in how he lives, where he works, right? It makes his life actually possible in many different ways. Rather than insisting that immigrant health is limited to the visible space of formal healthcare pathways, landscape privileges immigrant and rural knowledges and experience of place, why place is important, why sort of rural sort of nature of things is important, what time means, what seasons mean, and how that actually impacts the care that people get, and social relationships most of all. Landscape, I think, reveals the violence of the racial capitalist logic that drive our national healthcare and immigration policies and influence the local practices of caregiving and care seeking. Existing systems to treat immigrants and the working poor in rural America at their core are critically inadequate, they're racist, and they're exclusionary. Immigrants and rural providers manage and navigate this reality by engaging in complex social relationships and mutual aid to care for themselves and each other, where care is a site of cooperation, it's a fellowship, and recognition that refuses the dominant modes of claiming immigration and rural health as overdetermined by suffering and deficiency, as well as a transactional relationship that is all about money. Landscape of care on the Eastern Shore is a terrain. It's a politic, right? This is politics as it is being actually lived. It's a political struggle for belonging and placemaking. And what this book and the research says is that it's a vital feature of immigrant life, right? This is what makes rural living possible and what makes immigrant life possible in rural settings. And I would argue that it's a very sort of strong politic. It's not just resistance, it's not just strategy, but it's the politics in itself. The care is a site of a political struggle that's happening.